All right. Perfect. Okay, so if there's nothing else, then Arlette, you will be presenting a case today.
Well, let's start. My client is, can I say his age? Joy, is that okay if I share his age?
Yes. Yes.
Okay. So he's 8 years old and 5 months, and he has been we have been working with him for the past 3 to 4 years, and he began services with very severe challenging behaviors, like severe self-injurious behaviors and environmental destruction. And we have been able to modify his challenging behavior and successfully reduce the majority of the severe behavior to the goal that was established for him. And the only challenging behavior that we have not been successfully able to reduce has been screaming, which of course it's still a huge improvement for the family and for us as well to be able to reduce from self-injurious behaviors to just screaming. However, it's still preventing him to be an active member of his community and still a barrier in his learning in school and just overall social interaction at home. So that's why it's important for us to tackle that behavior still. The description of this behavior is occurring across different settings, including with parents, with in therapy session, with teachers. It has also been displayed when it's by himself, when he's completely by himself in free time. And it has also been occurring when either a preferred item is removed or when an instruction is being placed, when there's any type of transition from preferred to non-preferred activities, or also from non-preferred to preferred activities. So it appears to be happening across all types of condition of a typical FA, but we have not done an FA on him for this behavior. He's currently following the ViviMap assessment curriculum, and he's not receiving any other ancillary services right now except speech pathologists from school. He has been working on communication skills since the beginning of treatment, successfully been able to increase manding repertoire to multiple utterances. He has been able to work on weighting skills, manding for more time with current reinforcement or current activity. He has been also working with manding for negative reinforcement for non-preferred activities or non-preferred items, or for breaks. He has also, in his history, he has been diagnosed with autism spectrum disorder level 3 and anxiety state unspecified. And then he also has a diagnosis of echolalia and ADHD. He's currently receiving medication for Celexa, Focalin, and then melatonin for sleeping at night. His sleeping patterns are currently appear to be normal. He goes to bed around 9 p.m. and he stays asleep for the entire night. He wakes up until 6:30, and he's able to go and to the restroom and change by himself completely, but he's still displaying this problem behavior throughout these activities, even if nobody's placing the instruction. And it's not for every day, but the majority of the times he's still displaying that behavior. The primary language in his home is English, and the same at school. It's also English, and he is placed in a structured learning unit where he attends 5 days a week, and he receives only 30 minutes of speech per week. He used to receive respite cares, but not currently, and he lives with his mother, father, and he has 5 siblings currently living with him. That brings us to one of the barriers in the treatment has been parent involvement. So one of the like I mentioned, one of the main goals that has been on his treatment has been communication goals vocally. We began with vocal mending, and he has been successful with that. So we have also worked on intraverbals and echoics for him. And he uses about 2 to 4 word phrases. The only communication challenge that he presents right now is pragmatics and conversational skills. He always uses communication skills for preferred items, for adult attention. He frequently uses it for peer attention, and he has seldom conversational skills, and he frequently asks for social games. He never asks for where items are located, but we're working on managing for missing information. He is frequently asking for breaks, and he's always asking for removal of aversive tasks. And he's frequently asking for help with difficult tasks. And let me go to the barriers really quickly. So the main barrier, like I mentioned, is family involvement. We have been able to successfully present foundations and principles of ABA to parents, and we have been able to implement toileting and adaptive living skills strategies with the family, because it was a main priority for them. However, with behavior strategies, we have been unsuccessful to have them participate mainly due to schedules conflicts for them, and just their busy daily routine with the other kids, and both of the parents work. So it's been challenging for them to participate in this. And we have, I don't know if that will be shared on the screen, but we have been used different antecedent and consequence strategies for him. And per a recommendation of actually Sarah Brunswick, we have been working with him on level tone of voice level to teach him different tones of levels of tone of voice. But that's the main barrier to get parents on board with the procedure. And sometimes we will have, not as frequent, probably we will have 2 to 3 times that he screams during session time, and parents don't get involved, don't intervene. But when he has probably 5 to 10 during a session, then parents will come in and will intervene. And so we are unsure if we're getting some accidental reinforcement, as we are not 100% sure what is the function because we don't have an FA. But we have hypothesized that he has a multiple function maintain behavior for the screaming. And I believe that's everything that I have so far. I don't know, Joy, if you would like me to cover anything in more detail.
Yeah, I think it'd be great if we could go ahead and I know that you had some data that you had brought as well. And so if we can go ahead and just, I thought that this would be relevant for the team.
Yes, so this was a functional assessment screen tool that the parents fill out at the beginning of the assessment, which was 3 years ago, but then they also fill it out again a year ago, and it still showed the same data. So as you can see in here, we have a potential function of socially possibly reinforced by attention or preferred items, and then also negatively reinforced by escape or delay to task. And then we have some data for 3.4 for automatic when it's pain attenuation. And I think I also would like to mention in here that he suffers frequently of stomach difficulties. So sometimes he will not be able to use the restroom for a long time, and then sometimes he'll suffer from diarrhea chronically. So it goes in cycles, and we have not graphed any correlation data between that, but we have the problem behavior with just events on when he is sick. Another factor that he does have frequently changing in his physiological state is frequent changes in medicine. I believe he suffers, I believe one of the medications, according to his psychiatrist, the brain gets used to it, so they have to change it about every 6 to 12 months. And sometimes as well, we have observed or we have experienced that due to the family schedules, they would run out of medicine and not have medicine probably for a few days and until they get it back. So that has also been another barrier. We had an appointment with his specialist, and he ruled out any specific problems from the stomach, and he didn't prescribe any medicine for him or any treatment for him. So per parent report, we have that document. And he also has cross-sight. So sometimes we will not be able to find his glasses, and because of the parent low involvement, we will not be able to have his glasses, so he's not able to actively participate in these pre-trial sessions. So those are the main barriers, and I believe that I believe that's why it's showing on number 1 and number 3 points for automatic sensory stimulation pain attenuation data.
Thank you, Arlette. I really appreciate going through that piece of it. And somebody chatted in that they were not able to see the entire screen. Are all of you able to see the slides in their entirety? Okay.
Yes.
Okay, just wanted to make sure. Okay, wonderful. So I'm going to go ahead and briefly summarize the case, and then we'll move into audience questions. But basically, we have an 8-year-old boy diagnosed with autism and has been receiving treatment for approximately 4 years. ABA treatment. There have been a multitude of challenging behaviors that have been targeted over this 4-year course of treatment. You have successfully observed some decreases in these other targeted behaviors of concern. One area that has been a little more challenging has been the vocal stereotypy in the form of screaming that appears to be affecting his ability to participate in treatment, social situations, and it's also affecting the home environment and quality of life. In consulting with some colleagues, you have implemented some interventions and are observing some improvements and are looking for some recommendations as to how to proceed with potentially identifying more accurately the function of the behavior. And once that has been identified, then are looking for treatment recommendations that could be implemented within the home that also can take into consideration the treatment barriers that were listed.
Yes.
So does that cover everything and your main primary questions?
My main primary questions is, I guess, recommendations on how to tackle those parent barriers. And I also want to mention that we haven't been able to do a functional analysis due to the parent schedules and setting where he's located in the home as well.
Okay, perfect. Thank you so much, Charlotte. I appreciate that. That was an excellent summary. Okay, so we are going to open up questions for everybody in the audience. So if you have a question that you would like to ask about the case, treatments, or just any other clarifying questions, please feel free to do so. When you do, please introduce yourself. So for example, you would say, "Hi, this is Joy," or "Let I have a question about XYZ."
Hi.
Yes, you can just unmute yourself when you're ready.
Okay. I'm Sarah, and my question for you, Arlette, I know that you mentioned you kind of hypothesized at this point that screaming might be multiply controlled. I was curious if you had done, have you screened for an automatic function yet at all? It's a tool I often use sometimes when I'm limited, but I think in this case, most often I've used it when I actually hypothesize automatically maintained behavior. But essentially it would be a series of 5-minute alone conditions wherein you could do it with the current barriers you have. I can also send a link to the research article that might be helpful. That's one direction I would go. However, if your data is pretty strong in suggesting the multiply controlled behavior, as it looks like from the FAST it does, then I'm not super sure how useful this would be. But if you really feel limited that you couldn't do a functional analysis, this would at least potentially add more evidence for your thought that this could be multiply controlled.
Yes, that would be great. I would definitely love to see that tool. We do believe that it could be automatic for some of the situations, because he would, for example, even when he's doing toothbrushing, he will look at the mirror and then he will scream and then he will make faces. So we don't have data to just show that it's only automatic, but that would be a great tool to attempt to try for sure. To see if we have stronger data. Thank you.
That was an excellent question, Sarah. And so after, and I apologize, I also should structure the rest of the session as well. So with this section, we'll ask questions to clarify, and with the next section, we'll provide recommendations exactly as you just did, and I think that's wonderful. And so we'll be looking for the link to that recommendation from you, Sarah, as well. So I appreciate that.
Miss Arlette, I had a question for you. For this client, what would you say are his interests and his leisure time activities?
Yes, that has been, that's a great question, because that has been one of the main concerns of parents as well. Previously, because he didn't have any play skills or any leisure skills, he would just listen to music and rewind the sounds, and the family has decided to move away from that because it was creating more challenging behavior, the severe ones, for when we were transitioning him to another task or activity. And we have been teaching him independent play skills, which data reports and then family reports as well. He has been successfully engaging in appropriate play during his free time. And it appears that some of the times, for example, he would display this challenging behavior when he's still playing appropriately, or sometimes he will display that inappropriate behavior while throwing the items, or when he cannot play something, like if the toy didn't open the way he wanted. But then sometimes he will display it when it is working appropriately. The majority of his preferred items are Minions, Angry Birds, and he does really well with puzzles and playing appropriately with cars and trains and reading books. He has been successfully displaying all of those appropriate skills, but his favorite of all the time is watching TV and rewinding sounds, which he doesn't have too much access to it unless somebody's new in the home and they let him watch something preferred. Thank you for your question.
Excellent question.
I had a question, Arlette. This is Nick. So I think it's, I think we'll get to the recommendations in a second, but I think it's key that you're utilizing the VB map, because it sounds like there's some communication deficits here. I was just curious, based on the fact that you're working on the interverbal repertoire, I'm assuming he's a level 2 kid on the VB map?
Yes, he has actually mastered manding across level 1 and level 2, and he's halfway level 3, I'm sorry. And he has had generalized some communication skills as well to school. One of the barriers that we had previously was that the school was using text communication with him, but we had an observation and we successfully developed that collaboration to push for the vocal communication, which he has successfully done in the past 6 months. but he has the foundation interverbals from level 1 so far.
And now with his manding, I know you'd mentioned before he can mand under the control of the item. It sounds like he can mand under the control of the motivating operation. But you said for missing items, that's one of his barriers as well.
Yes.
Okay. All right. And my other question too was with are there any verbal operants that are lower than the others in terms of like is attacked less than, or are they all pretty consistent with one another?
They are all pretty consistent. He has successfully mastered all of the echoics from the portion of the VB map. And then he has also successfully and just consistently progressing through tax. He's doing really well with tax at level 3. And he, like I said, with manding as well, he has been progressing consistently. And listener discrimination as well. He has been consistently through level 3.
Okay. I'm sorry, just 2 more quick questions.
Yeah, no, definitely.
The mand itself, is it under the control of the item or is he manding more? So for example, if there's a cookie in his environment, is he able to say cookie or is he manding more than he's just getting the cookie because the cookie is the item available?
He's manding from 2 to 4 phrases, so he's able to say, even if the item is not present, he will go and look for the parent and he'll say, excuse me, so he'll mand for attention first and he'll say, I want some juice, please.
Okay.
So he's able to do all of those steps to search for the listener and ask and mand for the item. So without the person present, without any question, and without item present as well.
Okay. And my last question, on the VB map under the play skills, so his play skills are pretty consistent with everything else?
Play skills, we started at the lowest. That was the lowest baseline that we got across all of the other skills. And we had increased the time that he has been playing appropriately. He has very strong imitation skills. That's his main strength. So we were able to do a lot of play imitation, play outside and independent play. And we were working on turn taking for items that he knew already how to play. But he still doesn't have social play or parallel play. Parallel play he has, I'm sorry, but he doesn't have social play. And for independent play, we're still working on increasing time for 5 preferred activities. And one of them he mastered up to 15 minutes, and the other ones are under 5 minutes. He hasn't met the goal yet for the other 4.
Okay, so based on the analysis of the VB map, you'd characterize the play skills probably as one of the lower operants at this point, or the lower skills in the VB? Okay.
Yes. Mm-hmm.
All right.
Excellent questions. And Nick, do you mind sharing why you're asking questions related to this area?
So right now, typically it's based on the observations conducted. It sounds like it's a multiply controlled problem behavior. Typically in these kinds of cases, what I always try to focus on is build up that communication repertoire as much as possible. If there are deficits in the communication skill, again, the focus should be, in my opinion anyways, building up that communication repertoire as much as you possibly can. So I think it's important to kind of understand where the deficits are in the verbal behavior programming. But 2, and another area that I would focus on too is the enrichment of the environment with play activities. And it sounds like one of the deficits in this learner's VB map assessment is the play skills. So that would be an area of target to build up those play skills. So again, we're enriching that environment with more reinforcers, which will hopefully function as a abolishing operation to decrease the value for the screaming.
Yes, thank you. Yeah, definitely. We have been even working with him now that he has mastered the majority of the independent play to up to 3 minutes. We have incorporated them in an independent activity schedule where he completes maybe playing with the trains for 2 minutes, then playing with the cars for 3 minutes, then playing with the Angry Birds. And he has been successfully mastered that program of following the activity. We're now trying to teach him how to use a timer, so we increase the time. The main barrier for when we are not in session for the independent play is that the parents will have they haven't had involvement in providing him the activity schedule or in monitoring that he's playing appropriately or redirecting basically.
Mm-hmm. Excellent. Thank you. So those were excellent questions. And Nick, thank you for sharing the thought process. Part of the mission of ECHO is to help identify why we're asking these questions and the thought process behind it so that our participants are then able to apply the same information when they're working with other cases. So in the interest of time, what we'll actually be doing is moving on to our hub participants and getting clarifying questions from our panelists as well. So today what we will be doing is we'll actually go back and forth between our video hub participants and our on-site hub participants. So Tina, we will go ahead and start with you, and if you have any clarifying questions.
Hi, everybody. Arlette, I'm wondering if you can give me a little more information about the history of this particular behavior, and if you already presented that, I apologize, but just how long has this been an issue for the client, and has there been any notable points where things have been worse or better or increased with regards to intensity or frequency?
Yes, definitely. This behavior has always been present since ran services with him 4 years ago, but it was in conjunction, it was always happening in conjunction with what we defined for him tantrum, which was flopping on the floor, kicking in, his legs, and hitting his arms, throwing items, all environmental destruction, biting, and then self-injurious behavior. So it was always happening in conjunction with all of those other behaviors. So we were not tracking the level of that screaming by itself since the beginning. But once he met mastery criteria to decrease the tantrum definition and the self-injurious behaviors, we isolated the loud vocalization to be tracked by itself, and that began 2 years ago, but that data has been consistently at the same rate per hour for the past 2 years. We have noticed increase right after holiday breaks or summer when he goes back to school. We have noticed an increase, probably about 20% more per rate, but it has never gone down completely to the goal that it's reduced by 50%. And the times that we have noticed that it has been a less per session, the rate has been lower. It has been during days where he had a relay at school where he didn't have any problem behaviors and where he didn't have access to electronics during the day. So when he does have access to electronics during the day prior to session, we do observe a higher rate for that session. But it's still the same level, and the data doesn't show any tendency so far for the past 2 years.
Got it. Okay, that's really helpful. Can you also help me better understand the topography of the behavior? And I know that you provided a really great operational definition in the document that you presented, but I'm just trying to get a sense of whether it looks more like yelling. The definition, it sounds like the way it's written could capture both yelling, so very loud, perhaps inappropriately toned, vocal verbal language, but then also include vocalizations that are not vocal verbal vocalizations that would be more in line with sort of the lay conceptualization of screaming. So I'm wondering if it does include both, if there's a difference in what you see with regards to frequency of maybe yelling versus non-functional screaming.
Right. It has always been non-functional screaming. The only functional loud vocalization that he has displayed is the word no, but then it's always followed by a non-functional vocalization.
Okay, got it. That's also really helpful. And then the one other question I had was, you mentioned earlier that you haven't done a functional assessment, and you also mentioned that part of the reason is related to the parent barriers. And so I'm curious about how you, about how the location of your sessions and how the parent barriers are prohibiting conducting an FA, And as a second part of that question, if in lieu of an FA, you've at least been able to collect some descriptive assessment data, some ABC data that might help us get a better sense of whether we're on the right track with conceptualizing this as a multiply controlled behavior.
Yes, definitely. One of the they recently moved to a new home about a year ago, and they have set out the entrance of the home to be our therapy area, but it's an area that is shared with the dining room, and then he has his own room that we could potentially use for an FA. But the reason why we have approached it before, but it has been conflicting with scheduling, with parents' schedules to be able to do the assessment, the analysis, and then just overall control of the environment. We don't have full control of that environment like in other homes. Say we have less control in the environment due to the family number being that high. We could possibly do it. Maybe I just think I haven't been successful at convincing parents on doing this assessment.
And the descriptive FA data, or the descriptive assessment data, has that been something your team has considered collecting?
We did, yes, we do have records of that. I don't have it with me right now, but we do have descriptive data, and data was collected at the beginning of the treatment 4 years ago, but then we collected it again in a new setting at the daycare, and then we also collected it when he came to his new house, and all the descriptive data pointed towards multiple factors as well, to both functions.
Okay. Sounds good. Well, I think I'll pass it to somebody else for questions, but thank you. That was very helpful.
Thank you.
Thank you. Kathleen?
Sure. Hello, this is Kathleen from Oakland, California. And Arlette, I had questions related to the family involvement treatment barriers. Specifically, I was hoping you could share with us your goals for the most basic family involvement that you would desire.
We have successfully in the past convinced them to participate in meetings to explain the treatment once a month. Then we moved to successfully have them have a meeting with us still once a month, but to cover specific strategies that we were using to hopefully share them with them for implementation. And they expressed that they understood, and they schedule the following meeting for practice. So the practice portion has been the one that they always reschedule or cancel. And what we have been doing so far is just collect data when they intervene or where they don't intervene throughout session naturally.
Okay, great. And then my next question was just to identify what might be realistic for the family in terms of involvement. Can you share a bit about the parents' schedules, and specifically when you're holding a session in the home, are both parents typically present or just one?
Yes, that's a great question. Both of the parents are attending school, and both of the parents work full-time. And like I mentioned, they have 4 kids. All 4 kids are over the age of 9 years old. So if that is helpful, and actually the kids participate in session, I would say 3 out of 4 sessions a week. They help us with bringing items that we may need for session, or they sometimes participate in social skills goals as well. They have participated tremendously for communication skills, but sometimes, for example, if we ask parents to participate, they will send one of the kids instead because they have to study, and the dad used to not be home for all the sessions except one. But now he has been successfully arriving for half of the session towards the end every day. But it's when we do his nighttime routine, when he's working on adaptive living skills. So when we had to schedule the meeting for parent training, it had to be outside of this typical session routine, which was perfectly fine with us. But trying to coordinate future meetings has been unsuccessful for their current school and work schedules.
Thank you.
And then I'm going to go ahead and pass off to Zoe now.
All right, I'm unmuted. Hi, I'm Zoe Miguel again, licensed independent social worker. And I had just a couple of questions in terms of, has there been any data collected at school? Is the screaming of a lower frequency at school?
We do not have any data from school. That's a great question. Yes, we do not have any data from school. In El Paso school districts, when our clients are based in special education, they have provided us with information that we are allowed to do only 6-hour observations for a whole semester. So when we did the observation for the past semester, we did it for collaborating with demanding and communication goals, but that would be a great idea for sure. We have not collected data on that yet.
And I also wondered if you had any chance to speak with the speech and language pathologist in the school environment.
We have not been able to communicate with her either. In the previous IEP meeting, she was unfortunately not present, and trying to communicate with her via the in-home trainer has been unsuccessful due to her schedule as well. That's a great question, for sure.
Have you done any, we talked last time about treatment barrier scale, and Joy, thank you very much for sending this out. So I was wondering if something like that had been done, or if any discussion had been had with the family in terms of what has been difficult and what might be some potential solutions.
We have definitely addressed with parents concerns about that in the past, but not formally from a scale. So that may be a good idea for sure, to do it with a scale. Mm-hmm.
One further question for clarification is, it sounds like some very challenging behaviors have been able to be reduced significantly, and this is sort of one last piece of it. And I was wondering what your thoughts were of why maybe parent involvement was higher with the other behaviors, or why this one has kind of stuck, and parent involvement has been enough historically to help reduce behavior, but this one in particular is proving to be difficult.
Yes, definitely. That's a great question. In the past, he would typically display problem behavior, for example, the tantrum behavior, or aggressive behavior, or self-injurious behavior. So when that would happen, it would affect items in the house, it would affect other people, the siblings getting hurt, or himself getting hurt. So we had to make sure that he was safe. And then he would also display typically self-injurious behaviors in the mornings when his diaper was full. So then his whole room will get dirty. So that was also a high priority for parents, because then he would start ingesting his bowel movement. So I think the motivation from parents was higher than to be involved, because the behaviors were more severe and were affecting other people in the home as well, and definitely was putting him at risk. And this behavior, when he screams, parents will be like, okay, well, just send him to his room, or just ignore him and just walk away. Just, we'll have to deal with it. As opposed to let's do something about it as before. But that's a great question. I think that scale may be really good for sure.
Great. Thank you. Great information. I appreciate it.
Excellent questions. So we are coming close to an end, so I'm going to try to make my questions quick so that we can get onto the recommendations, which I know is the piece that you're looking forward to. So one of the questions that I had was related to what Tina was actually mentioning. So I know that we haven't conducted an FA. I do know that you have experience with conducting trial-based FAs, and there might be some other modified FAs that could be appropriate in the setting. So I was wondering if you had just considered any of those at this point.
Yes, we the one that we had considered was the trial-based FA, and we had mention it to the parents, but that's the one that I'm trying to convince them to be on board for.
Okay. And when you're mentioning it to the parents, are you requesting that they're running the trials themselves, or that it would be implemented during treatment sessions by the technicians?
I am indicating that I will run it myself and that they can observe online to make them feel comfortable. But then I have also mentioned that I would probably ask them to run some trials because if needed after the ones that I would run, because a lot of the behaviors are also happening with them. Behaviors happening frequently with them as well.
Okay. And then one piece that we had asked as well was that one of the activities he really enjoys is watching movies and listening and repeating some of the auditory components. And so do you just have any anecdotal information about the frequency of the vocal stereotypy during those types of activities? And the reason why I'm asking is sometimes we'll do competing items preference assessments to see if we see a lower frequency of these behaviors occur while engaged in some of those activities.
We do not have any data on that. We don't have any data on that yet, but that would be great to take.
And my final questions are related to some of the consequence procedures. Have you implemented a response interruption and redirection procedure when he does engage?
Yes, it's part of his current plan. But I think we do have some conflicting strategies for this portion. We have interruption, but it's without paying attention. So it has to be just redirecting to the activity. So we're not redirecting to a replacement behavior per se.
Okay, perfect. All right. Well, thank you so much for clarifying those questions. So now what we will go ahead and do is move the fun piece, recommendations from our audience. We will be taking those recommendations here and sending them out to be an email to you, Arlette, as well as everybody else that's joining us today. So you do not need to know. Yes, and feel free to unmute.
Okay. I would say if you wanted help with the FA, I'm here local, so I can definitely help you with that. But regardless of what's maintaining the behavior, if you implement a DRO, so kind of bring attention, and then in that attention, it gives escape from whatever you're currently doing. If you have that time frame of the rate, you said that the rate hasn't changed, then if we just get right ahead of it before it happens, so we're taking a little break from what he's having to do and providing attention on the screaming, like, hey, you're doing a good job. I really like that you're using a calm voice, or whatever you think would work for him. I would recommend trying a DRO schedule.
Thank you.
No problem.
Any other audience recommendations? Sarah Bowman, I know we had one from you that we have listed as well. Thank you for that.
Oh, I do have one other suggestion. In addition to that is providing an opportunity of when it's okay to scream. And so making it clear we can scream when we're outside, we can scream when we're playing tag, give opportunities to get screaming out of the system, like take a screaming break, let's scream into our pillow. And that, does that make sense?
Yes, we currently have that program for him. We are working on that for sure with him right now. Thank you. That's a really good recommendation too.
Great minds think alike. Okay, so in the interest of time, we'll go ahead and move on to our hub panelists and get some recommendations. So Tina, would you like to provide your recommendations?
Sure. So I think this is always a conundrum for me, because I think that it's a complex case, and I think given the topography and everything you've described, it does sound like there's some data to indicate that it's multiply controlled. I think unfortunately for me, I'm not convinced, right? I'm sort of that hardcore behavior analyst who wants to see the data. I want the data to tell me beyond a shadow of doubt that this is indeed multiply controlled. Because I think in the absence of that either really well taken descriptive assessment data or that functional analysis data, what you're going to end up with is a intervention package that is really complex. And, you know, in reading over what was submitted, that's the way it read to me, that there's a number of treatment components to address all of the different functions. And the way they come together in some cases reads a little bit incompatible. And it sounds like even in your description of some of the components, there's more that's not even captured here. And I think that it probably makes it a little challenging, I'm speculating, but for the direct technician to implement with fidelity, but then also the parents to really feel like they can get in there and do this plan, because it would be a tall order for any really savvy technician to get in there and implement all of the different components of the plan. So I think if you can do what other people have recommended and try to find a way to get that more current, maybe slightly tweaked descriptive assessment data, inform your development of some nice FA conditions, you could bang out that FA even if you don't have full control of everything in the natural environment in a way that at least gets you going in the right track. And I think while it would be ideal to get parents in there to run some of the FA conditions or at least do a little bit for you, I would forego that if that's their biggest reason for saying no, right? If you can get them to green light the FA by them not having to lift a finger, then I'd say do it. Because again, if part of your suspicion is that it's automatically maintained, that's going to hold to be true regardless of whether they're involved in the FA or not. So that'd be my biggest rec. And I think that is going to point you down a path. You're going to be able to get the results that you want. I think other people have asked questions that have already pointed to some other really good recs. I mean, I would try to get in there and get that school data, as Zoe was saying, that having some sense of whether or not there is a difference between the frequency or intensity of that, non-functional vocalization at school versus home could also give you some indicators about some setting events and other motivational factors that you don't have sort of a pen on just yet. And I'm always a lover of consultation, and I think trying to get a sense of whether that SLP is doing some intervention strategies that maybe support what you're doing or may indeed be inconsistent with what you're doing, I think would be helpful. Yeah. And hold on, let me look. I have some notes over here. Let me make sure I'm not forgetting anything. I think that's it. I mean, those are my biggest. I mean, if we knew that function, I feel like I could say something about the utility of doing an NCR with a DRA, or whether or not it would make sense to do something to attenuate the automatic stimulation that occurs from the vocalization, whether it be wearing headphones or doing something to compete, such as chewing gum. But I think without that, it'd just be guesswork, and I don't want to. You know, I don't want to do that to you because you've already got enough in your plan already. But that's what I would say.
Thank you. Thank you very much. Yeah, that's we're definitely going to push for that FA for sure. That sounds like the best direction.
Yeah, I think so.
Thank you.
Of course.
Kathleen?
Hi, this is Kathleen from Oakland, California. And in terms of what Tina said, I think, you know, after that is complete and you have a plan you're feeling good about, I think one of the things that Zoe was touching on as well is sitting back down with the family who have goals in mind for that ongoing treatment involvement, and having a candid discussion about the barriers, as well as the fact that you understand there are absolute barriers because of the school and work schedules. It sounds like you've already been trying to determine what might be realistic and starting really small with the once per month meetings. So, you know, I would encourage you just to continue meeting the family where they're at and being open with them too, all the while. But it sounds like you're doing a great job at that.
Thank you.
Zoe.
So just to sort of tag on what Kathleen was said in terms of the family barrier, I thought that what you again, I'm Zoe from Santa Fe, independent social worker. What you were talking about of that the motivation for the family, the involvement of the family, seemed to really correlate with how important the absence of that behavior was to them, right? So when everybody the house was in danger of being wrecked everybody was sort of, their physical safety was feeling threatened. And so maybe thinking about how to impart to the family how important it is that his behavior decreases. And in your information that you shared with everybody, which was so wonderful and informative, you talked about it interfering with his ability to function in the community and be able to go out, and so maybe some of those examples would help them to really see that yes, it may be able to be solved in the moment by giving him something, a desired activity, or giving him something to do, or sending him to his room, but that doesn't really help him to gain the skills that he needs to be able to be out in the community and be independent and have friends and those kind of things. So I was just thinking about, ways that you might be able to increase that level of motivation for them. Sometimes, especially if we're in a chaotic home, it's hard I'll speak for myself as a parent, to kind of see how a certain behavior ripples right out. And so that would be a thought that I had, and maybe a recommendation, because it sounds like they really were able to get on board and effectively participate in the therapeutic process when it was something that they could really see the reward, right? The gain of it. So that was one of my thoughts. And also I just had some, like, the medication running out and glasses being lost, and so I'm not sure, that to me really speaks of like a life that's pretty chaotic. I mean, if he can't participate in sessions because he doesn't have his glasses, I think that has probably got very challenging for you all and for the therapeutic team, but also for the family. And so maybe that there are little things that can be done that will also help to maybe control some of the variables that may or may not be affecting the target behavior. And why isn't respite there anymore? That poor family.
That is unfortunately due to coverage from the insurance.
So anyway, those are my recommendations. I hope that's helpful.
Thank you. It is very, thank you very much.
Excellent. Thank you so much. So one of the things also that I wanted to share is that if anybody does have any recommendations, links, or articles, please send them to echoautism@behaviorchangeinstitute.com or put them in the chat box. Haley will include them in our recommendations that we'll be sending out. And, what I would like to share just as we quickly round this out is that I am very much in alignment with Tina as well with respect to, I think the challenge is that I also am not convinced that it's multiply maintained. And I think sometimes too what we see in analyzing the data from different areas, and I know that we're looking at a FAST, which is a questionnaire that was completed, but oftentimes when you're looking at a behavior that might be automatically maintained, you'll see that behavior emerge in that condition, but also another pattern is you'll see it emerge across all conditions. And so, with the absence of having more specific data, I think the other reason too why I'm not convinced as well is because there have been some great successes with reducing these other targeted behaviors, and it seems that if we're not, if we don't have the correct hypothesized function, these interventions then may not be targeting exactly what it is that we're needing to be targeting as well. And since it's been persisting for 2 years, it seems that maybe that would be the best approach to focus on that piece of it. And so what we'd like to do is follow up. There is an article on different modifications to FAs that we will follow up with that allows us to be able to modify these FAs, write them more in a natural setting, as well as, piggybacking on with what Tina said, I think that if we can run the FA ourselves and not require the parent involvement for this piece, that would be amazing to be able to have that information, and then invite you to come back and present the results of your either modified FA or descriptive assessment that you're going to be doing, and then we can go ahead and provide some recommendations that are targeted needed for his intervention in particular, and hopefully be able to help narrow it down as a team as well. So we'll follow up with some resources as well within the email, and please do share the information too. I think that we have a very wide breadth of knowledge between all of the behavior analysts that are here today, and I know that there's some recommendations that we didn't have time for you to share, so we'd love to be able to get that from you all as well.